Welcome to Personalizing Multidisciplinary Care for IBS with our two amazing guests, Kate Scarlata and Dr. Riehl. We're really excited to bring this to you. Mindset Health, this is part of our ongoing webinar series, and this is definitely an extra special one to have you both here, so thank you. A couple of quick housekeeping things before we get started. There will be a Q&A at the end, time dependent. So if you have questions throughout the talk, please submit them in the Q&A box on the right-hand side. You'll notice that the chat is actually separate to the Q&A. So if you could submit the Q&A questions in the Q&A box, and then you're more than welcome to chat in the chat as well. But we'll be pulling those from the Q&A box specifically. We also have, this is the first time we've done this, but we are giving 3 licenses, Nerva accounts to all the providers that watch this live or watch the recording after the fact. So check your email for that. That is definitely something we've never done before, and hopefully it's a good perk for yourselves and for your patients as well. So that's sort of all the housekeeping. So I'll go ahead and introduce Kate and Megan. Kate Scarlata is a Boston-based registered dietitian and New York Times bestselling author with 30 years of digestive health experience. She's a world-renowned low FODMAP diet expert and invited speaker at many different conferences. She's spoken at Harvard Medical School, Monash University, and many, many more. Kate specializes in digestive health, including treatment for IBS, celiac disease, IBD, mast cell activation, and small intestinal bacterial overgrowth. And Dr. Riehl is a health psychologist and expert in the management of GI and chronic health conditions. She's an associate professor of medicine at University of Michigan, and she's involved in various professional GI organizations and patient advocacy groups. Dr. Riehl is an expert in the delivery of gut-brain behavioral therapies and also provides educational lectures, consultations, supervisions for colleagues, and also many, many more areas of expertise. Kate and Megan have both just published their new book called Mind Your Gut, and also launched the Gut Health podcast. So I really encourage you to check both of those out. All right, well, I will hand it over to you.
Thank you so much, Claire. Hello, everyone. It's really interesting and exciting to have an international audience, seeing people from around the globe. This is so incredible. All right, so I'll briefly go over the objectives. We're going to provide an overview of the global burden of disorders of gut-brain interaction with a focus on irritable bowel syndrome, discuss the evidence-based nutritional therapies available, discuss the GI stress cycle and cycle breakers, review the role of psychological therapies, including cognitive behavioral therapy and hypnotherapy in treating GI conditions, and highlight the importance of screening for disordered eating in patients with GI conditions. So we've learned from recent research looking at the role of using just a gastroenterologist in IBS care versus a multidisciplinary care approach. And we have learned that using multidisciplinary care is much more superior. Patients improve more efficacy to the treatment when you're utilizing a multidisciplinary clinical care approach. And this is really the new gold standard of care. And we're seeing this more and more for sure in the US. So that's involving diet and nutritional management, as well as the gastroenterology, medical management, and the GI psychologist. The global impact of disorders of gut-brain interaction is quite significant. This is a large global epidemiology study. It was an internet survey study that had over 54,000 people from 26 countries. And what they found was that 40% of this cohort had one disorder of the gut-brain interaction, and of those, 32% met criteria for more than one region. Looking at that and understanding that those that had more than one DGBI had, in more than one region involved, had lower QOL, quality of life, more psychological issues, higher rate of doctor's visits, and higher healthcare utilization. So when we wrote Mind Your Gut, we really focused on what we call the dream team approach. And that is really giving and providing access for individuals with GI conditions, access to a gastroenterologist, a GI registered dietitian, a GI psychologist, but also potentially pelvic floor physical therapists, particularly for those with pelvic floor dysfunction or dysnergic defecation, social worker, nurse navigator. Really, patients deserve a team. This is a chronic illness that can be quite debilitating. And the more treatments and opportunities to interact with different providers that are offering different treatments provides a better approach for these patients. So I'm going to segue into my area, which is nutrition. I've been a dietitian, as Claire mentioned, for way too long, 30 years. And when I started in nutrition, we had really zero outside of eat high fiber for IBS. And it's just wonderful to see the interest and the research expanding in this area in regards to nutrition and IBS. But we know that food-related symptoms are quite common in patients with IBS. About 90% of people with IBS associate their intestinal distension and pain with food intake. They also, 9 out of 10, choose to eat less food to lessen postprandial discomfort. And that can be a problem when they are not meeting their nutritional needs or it's impacting just their relationship with food, which Megan will talk a little bit more about later. So food intolerance is the most common type of food-related reaction in IBS, unlike food allergies, which involves an immediate immune response. Food intolerance tends to can occur over the spectrum of 5 hours, 20 minutes to 24 hours. It occurs very commonly. 15 to 20% of people in westernized countries experience food intolerance. And it can run the gamut from carbohydrates, which are the common triggers in IBS, lactose, fructose, FODMAPs, and in some patients, sucrose. Protein intolerance in the form of gluten or amylose trypsin inhibitors, another type of protein in wheat, have been associated with food intolerance reactions, certainly in celiac disease. And then A1 beta casein is a protein in some milks that has been shown to trigger diarrhea and symptoms similar to lactose intolerance. And even biogenic amines, which is histamine, which can be found in fermented foods and aged foods, has been associated with IBS symptoms as well as hives and flushing and other extraintestinal symptoms. When you look at IBS patients, and of course we want to do a patient-shared decision-making approach to their care, when asked, and this was a survey study of about 200 survey respondents with IBS, the most preferred treatment was dietary intervention, close to 50%, and this was followed by medications at 29% and psychotherapy at 23%. Megan, I'm the winner, just so you know. That'll change. That'll change. So what's the evidence for diet in IBS? Well, the diet with the most evidence and most research out there is the low FODMAP elimination diet. And this is a 3-phase strict elimination diet where FODMAPs, a group of small, commonly malabsorbed carbohydrates that are fermented and bring water into the gut, are removed or restricted. In this diet, they've done systematic and meta-analysis reviews. This is sort of the top tier where they're looking at all number of different kinds of studies to see, does this show clear signals that it's beneficial? And in a number of systematic reviews and meta-analysis, the low FODMAP came out superior to habitual diets or other diets that were studied. It's known to improve symptoms in about 50 to 80% of people, particularly with pain and bloating. Another diet that is not yet evidence-based, it hasn't been quite studied yet, is a FODMAP gentle or flexible approach. This is it's looking at the low FODMAP diet, but doing it more liberally, cherry picking out high FODMAP foods based on the patient's intake, what you think might be more problematic. And in clinical experience, I love this diet. It's a lot easier to apply, and you can really use the art and science that we often use as dietitians in practice. Another diet with some evidence is the traditional dietary advice from the UK, or the NICE IBS guidelines. We used this as sort of our benchmark for the gentle diet cleanup in our book, Mind Your Gut. It's really just cleaning up the diet, making sure people are eating meals, not skipping meals and then binging. Limiting certain indulgences like alcohol or overdoing caffeine, restricting sorbitol foods if patients have diarrhea, or adding some flax seeds if constipation is present. So really just kind of cleaning up the diet sensibly. And in one study, the traditional dietary advice had similar results or benefits to symptoms as the gluten-free and low FODMAP diet. And I'll review that briefly in a moment. Other diets that have been looked at more recently for irritable bowel syndrome is the Mediterranean diet. The key features of this diet is, a plant-forward diet with, extra virgin olive oil, nuts, seeds, legumes, whole grains, cheese and yogurt minimally, lots of fish, and minimal meat products. So primary studies have looked at IBS in the Mediterranean diet. The first was an open label study, which is not necessarily the best sort of protocol, but they did find similar response rates to low FODMAP in the gluten-free diet, but the patients really preferred the Mediterranean diet. In a second study done by Heidi Stodacre, this was a randomized controlled trial, and they looked at putting people with IBS on a Mediterranean diet compared to them maintaining their habitual diet. And they found that those that did the Mediterranean diet had significantly better symptom response, 83%, versus those that followed their habitual diet at 37%. They also had greater improvement in their quality of life measures on the Mediterranean diet. They didn't note any changes in their microbiome in this study, which they thought might be a factor to some of these benefits, but that was an interesting side pit that they noticed. Another randomized controlled trial looked at the Mediterranean diet and IBS, and they didn't find that it really amped IBS symptom severity as an overall diet plan, but they did find that certain foods did trigger IBS symptoms in a certain group of patients. So in their sort of takeaway of this study was the Mediterranean diet may work for some, but is not recommended for all with IBS. And then the gluten-free diet, which is a diet that restricts wheat, barley, and rye, there is some benefit to applying this diet, but it appears in IBS primarily due to the fact that these foods also have FODMAPs, particularly fructans. So reducing them is reducing FODMAP content, and that's why individuals are benefiting. There does appear to be a small subset of people with IBS that do benefit from gluten-free, however. So, if someone says that that's the reason and you test their tolerance to fructans and gluten separately, you can help determine what it is in the food. So when we're looking sort of like what are the various diets, I've talked about all of these right here. And the one with the most evidence, as I mentioned earlier, is the low FODMAP diet. So I'm going to review that, and then we'll just touch upon the FODMAP gentle a little bit, and we'll just keep going. So what are FODMAPs? I'm under the assumption that this audience is pretty well aware of this acronym, but I will review it quickly. The F stands for fermentable. This is because these FODMAPs are small chain carbohydrates that are fast food for our gut microbiota. They create a lot of gas. The oligosaccharides are FODMAP fibers. They're namely fructans and galacto-oligosaccharides. Sources would be onion, garlic, and wheat, and beans, and some nuts. Disaccharide, the D in FODMAP, is lactose, which is a common GI trigger because many of us malabsorb lactose and many of us have lactose intolerance. And then monosaccharide, the M in FODMAP, stands for excess fructose. So when fructose is in excess of glucose in a food, it is commonly malabsorbed and pulls water into the gut. That can cause cramping and diarrhea. And then polyols, otherwise known as sugar alcohols, include mannitol and sorbitol. and other ones that are additives to sugar-free gum and mints. But mannitol and sorbitol are also found commonly in a number of different kinds of foods, from blackberries to sweet potatoes to cauliflower and mini mushrooms. So how do FODMAPs generate symptoms? Well, we know they pull water into the gut. This stretches the lumen, and that stretching can cause cramping and may contribute to the diarrhea with the excess water coming into the gut. They also are fermented, so we have a lot of gas that's going to stretch the colon, and that can cause gas and bloating in the colon. But we're also learning that in people that respond to the low FODMAP diet, not just anyone that tries it and doesn't respond, but the responders, they feel better on the low FODMAP diet. When those individuals eat FODMAP-containing foods, a high FODMAP diet, it's been shown in some small studies that increases a negative balance of the type of microbes that reside in the gut. And we're learning that the type of microbes that tend to grow are gram-negative bacteria, and they have this exoskeleton membrane called LPS, or lipopolysaccharide. Not to get too scientific, but I do find this very interesting. And that LPS activates the mast cells. These are immune cells in the gut. That mast cells then dump some inflammatory chemicals into the gut. Mast cells are residing right next to the nerve cells, and all of these chemicals, this mast cell activation and nerve cell interactions causes that visceral hypersensitivity or pain in IBS. And there's also data to suggest that in these individuals that are sensitive to FODMAPs, when they eat the FODMAPs, this cascade of immune activation also contributes to colonic permeability, or a leakiness in the gut. Again, this is a really heavy slide, and I apologize, but this is a very interesting study to me. I hope it's interesting to you. This is a study where they looked at different types of using sort of different types of stool sampling. They're looking at stool. They're looking at what microbiota are in the stool. They're also looking at what those microbiota are making, the metabolites. And what they did was they looked at IBS patients and controls, and they found that in the stool, before they put them on any special diet, that IBS cases either had a pathogenic looking type of microbiota or a healthy like microbiota. In other words, the health like microbiota resembled what they saw in the controls that they also studied. When they put these individuals with IBS and controls, the healthy ones, so these are they have IBS, but their microbiota is similar to a healthy person. When they put them on a low FODMAP diet, nothing changed. Their microbiota didn't change, and most of them didn't really respond to the diet. But when they looked at those that had that initial pathogenic, just the microbiome looked a little altered, not as healthy, those patients did respond more favorably. And when they went on the low FODMAP diet, their microbiota shifted to the control and health-like microbiota of their other cohorts that they found. So kind of interesting, because we know that not everyone benefits from the low FODMAP diet. And there's clearly some kind of signals that we're seeing from the microbiome that can help us delineate who may benefit and why it is that they're benefiting. In this particular study, they found that about 50% of the people with IBS in this study had that pathogenic microbiome. And we find that around 50 to 80% of people benefit from the low FODMAP diet. So I think that's interesting. I hope you do too. So further looking at some of this information, I've kind of touched upon this as well. This is work from Prashant Singh at Michigan in the US. Really looking at, and he's doing this in my studies, but also in a small subset of humans, looking at the role of this dysbiosis, so this alteration in microbes that occurs with a high FODMAP diet in those that respond to the low FODMAP diet. And when you feed the individuals the high FODMAPs, it activates the immune system, and then that little red arrow down makes the gut more leaky. So we're seeing that the colonic barrier is more leaky due to this cascade of effect on the immune system by the different types of microbes that are being fed by the FODMAP diet. Looking further at the food microbiota interaction in generating that pain sensation or visceral hypersensitivity in FODMAPs, this was a study looking at FODMAP specifically stimulating a microbe that produces histamine, like a lot of histamine, 100 times more than any of the microbes that were analyzed in this study. And this particular species is Klebsiella aerogenes, and they're capable of breaking down amino acids into histamine. And they're finding that this bacteria-derived histamine activates the mast cells again and contribute to that pain sensation. Just again, connecting food with visceral hypersensitivity via the microbiome. Okay, quickly, I'm going to go through the low FODMAP 3-phase diet. As you probably are well aware, but maybe some of you are not, this is a 3-phase diet, an elimination phase where all high FODMAPs are removed. That lasts 2 to 6 weeks. We determine sensitivities in the reintroduction phase or phase 2. That's when we systematically add back FODMAPs. And then the personalization is the phase that patients stay on as needed for symptom management, and we add back successfully reintroduced FODMAPs that patients tolerate back onto their plate. So you can see here, when we're working with patients, if they're eating a lot of apples and onions, we need to provide them alternatives that they can enjoy, that they like. We're going to educate them with grocery lists and label reading, making sure they're eating a balanced and healthy diet. And I always say, you know, this is a diet that is appropriate if patients feel ready and willing to do it. But if they're really stressed out about it, that stress, as Dr. Riehl will mention about that gut-brain axis, you're stressed about a diet, it's probably going to be counterproductive because that brain and gut are talking on pretty high levels with IBS. With the reintroduction phase, we select specific food choices in different FODMAP subtypes, and we're adding those back in systematically to test tolerance. And this just provides some examples of some of the foods that I use in practice when I'm testing tolerance to, say, fructans or lactose, etc. And we can start a little slower if a patient's very nervous about reintroducing. If they're worried that milk's a problem, I might start at 3 tablespoons of milk. That's fine. Work with the patient so that they feel comfortable with the reintroductions. It's a very important part of the diet. And then lastly, the personalization phase, we're adding back to the plate the foods that maybe you had restricted. If you pass mannitol, then button mushrooms are back on your plate. Add them back. If you pass lactose, add some milk back to your meals. This is just a little snapshot of some of the common high FODMAP foods. So excess fructose, apple, mangoes, pears, watermelon. There's no intuition with picking these foods for the most part. So it's really kind of understanding what foods are high and low, working with a GI expert dietitian, utilizing the Monash University app if you find that to be helpful. I use it in my clinic. But you know, you do need to kind of know. It's not something that you're just going to memorize. You're going to need a list. So as I mentioned, we have the low FODMAP 3-phase elimination diet. That's what we call a top-down approach. We can also look at this as a bottom-up approach, and that's where the FODMAP gentle approach comes in, or FODMAP flexible. And that's when we're only eliminating a few high FODMAP foods. We're assessing symptoms, see how the patient's doing, and then adding more modifications or challenging those foods once again and seeing if we have any wiggle room with those foods. So it's a less restrictive bottom-up approach. And that is what we call the FODMAP flexible. And here are some of the high heavy hitters for FODMAPs. We might only restrict some of these depending on what the patient is presenting with. I often use the 24-hour recall and then the patient's sort of thoughts on what foods they think are problematic for them when using this approach. I kind of mentioned this earlier, but this is looking at a gluten-free diet versus the traditional dietary advice or the NICE guidelines versus a low FODMAP diet. Their reduction in symptoms were pretty similar, so we would say they have comparable efficacy rates. But in this dietary trial, the patients found the traditional dietary advice was more patient-friendly, quicker to shop, less expensive, socially more acceptable, and easy to follow. And for this reason, I really think that it should be a first-line approach in a patient that is completely diet naive and has never tried any diet therapies for IBS. So, wanted to talk a little bit about just the fact that access is a problem. We need more GI dietitians. There's less GI psychologists than GI dietitians, so I'm sure that is another big area. But a couple points that I wanted to talk about in regard to this topic. GI dietitians that are knowledgeable in the low FODMAP diet are rest assured going to encourage their patients to go through all 3 phases of the diet. Unfortunately, many patients that self-do this diet, or even some clinicians, never talk about the reintroduction and personalization phase, and patients are on this diet forever. And that's never the goal. It's not good for a food relationship. It's not good for food quality. It's probably not good for the microbiome. So we really encourage, as a reminder, that the low FODMAP elimination diet, for the practitioners listening, that you encourage your patients and tell them upfront this is a 3-phase diet. We also know that accessibility to expert RDs is somewhat limited, and referral by GI doctors is somewhat limited. So I'm going to talk about 2 studies. One was a 2018 study by UMichigan, and they surveyed the American College of Gastroenterology members. They got about 1,500 responses, and they found only 21% of patients were being referred to a dietitian. So that's one area of access point that's a problem. And I did a follow-up study with UMichigan as well, and we found that actually 42% of the GI doctors and healthcare providers that we surveyed did not have access to a GI dietitian. So again, access is a problem. And we also learned that 77% of GIs are spending less than 10 minutes on nutrition education, and that is far too little a time. So so we have some limitations here, and I just can't emphasize finding a GI expert dietitian when possible, so that you can really get the time for your patients, or if you are a patient listening, that you get enough time and clarification on the diet and the diet needs. So with that, I'm going to move on to my colleague, my esteemed colleague, Dr. Megan Riehl.
Well, thanks, Kate, my esteemed colleague, and to Claire and team for inviting us. I have to say, as I've been listening to Kate, it's been so fun to see everybody around the world joining us tonight. So I'll make the transition, though I think what is always fun about this talk is that we're living in real life, or we're talking in real life, what we hope our patients have access to. And it's this team approach, the dream team, we call it in Mind Your Gut, where a registered dietitian, a GI psychologist, a medical provider all work to help a patient live with a diagnosis like IBS or any other GI condition for that matter. So as I kind of shift over and we think about this diagnosis, as Kate has started to point out, there's not just a food factor in patients that have IBS. There's all kinds of different complexities that can really be perplexing for a patient. So while they may be trying to, control their symptoms with food, they probably aren't thinking about the alterations in their microbiota, or the dysregulation that's happening between the communication pathway of the brain and the gut. And that when we take the time to explain to patients these multifactorial components to their diagnosis, which can include stress, psychological symptoms like anxiety or mood symptoms, food components, it all comes together and impacts the functioning of our digestive tract. So Kate's in charge. She's going to have to click my slide for me.
I'm ready to tweet on Twitter, but
you can tweet her away in a minute. We think about IBS from a biopsychosocial model, and this is again a way for us to educate patients to let them know that the roadmap to IBS is oftentimes very different for patients. So one person might have a history of trauma, which can make them more susceptible to a disorder of gut-brain interaction like IBS. And somebody else may have just a different genetic makeup that can make them susceptible. And so we see that our genetics, our culture, our environment early in life begins to shape the way our brain and our gut are communicating. And again, as we educate patients on this diagnosis, unfortunately, too many patients have been told, this is a diagnosis in your head. We did that extensive medical workup and nothing's wrong. And just, best of luck to you. Then when we start to think about the brain gut axis, they almost cringe sometimes and are like, oh, this is not in my head. And so I think it's almost our privilege and our really it's necessity to discuss the brain gut axis and how along our central nervous system, we can feel sensations in our gut more intensely based on, again, those early life factors and psychological factors. But then we can also, have it kind of go downwards where our stress can impact our gut, which then impacts, that basically bidirectional pathway can impact the severity of your symptoms, how frequently you have symptoms, how you manage your symptoms. And so when it comes to our outcomes, this is where the fun comes in terms of helping to improve the outcome of somebody that's living with IBS. Next slide. So let me dive a little bit into the psychological impact, where we do see that people with IBS have a 3 times higher risk of anxiety and depression when we compare those to people that do not have IBS. And we see about a prevalence of 29% of patients with IBS have depression, 39% have anxiety, and then about a quarter of patients are living with co-occurring anxiety and depression. Next slide. One more time. There we go.
I'm fired.
No, you can't be fired. You're in this with me. Okay. So I think that so we've got the idea of anxiety, depression being more prevalent. And then, I think a lot of times there is reality that the diagnosis is more prevalent in women, about 2 to 2.5 to 1. So for every man that has IBS, 2 women have IBS. But I think that it's interesting where 40% of women have IBS-C, so constipation predominant symptoms, where bloating, abdominal pain is really prevalent. And then the IBS-D is more prevalent in men. And so I get asked this a lot by patients, where they will kind of identify that during their menstrual cycle, their symptoms are a little bit worse or leading up to it. And the science shows us that, when we look at estrogen and progesterone that can obstruct smooth muscle contractions, and that smooth muscle cell lines the wall of the stomach and the intestines and contracts when we're eating, and that when we're experiencing menstruation, those symptoms can intensify. And that's oftentimes because of the hormonal changes that can happen. And so, then if we look at the male gender, it's actually been shown that the androgens, that are sex hormones, can be protective against chronic pain. And so testosterone has again been shown to kind of help with the management of pain, which is something that people that have IBS-C suffer with pretty tremendously. So unfortunately for us women that, do go through these hormonal changes that don't just stop at menstruation, we want to be mindful of keeping that into consideration and really helping to make sure that women have lots of different coping strategies. Next slide.
It's not me, seriously.
When we also have looked at women that have IBS and looked at psychosocial stressors and how this can have an impact on their quality of life, we do tend to see, again, in the female population, lower quality of life, more fatigue, more depressed mood, having a less positive well-being or a sense of self-control, and higher levels of anxiety in those women that have IBS compared to men. And I think that goes back to what I've just talked about, is there is a role of, the types of IBS that a woman might be suffering with. And again, if we think of more pain symptoms, chronic pains can have a profound impact on many of these features that have been described here. So I think it just goes to, start to set the stage that we have to have lots of coping strategies. And we also want patients to understand that they're not alone in this diagnosis. And we've come a long way in terms of not just addressing the nutritional side and the medicine side, but also highlighting the improvements in quality of life that can be achieved with behavioral therapy. Next slide, please. So additionally, I think I always find the number 45 million Americans and about 1 in 10 globally suffer with IBS. But in my mind, I think that that's probably a gross underestimate. And the statistic really highlights that. So about 1 in 5 people with IBS do not want to discuss their symptoms with providers. So we identified this number in a research study. And what I think is important to keep in mind is, number one, there's a whole lot of people out there suffering at home. And therefore, they may be more likely to be turning to the internet or to be suffering in silence. And that's where our job as clinicians is to really begin and continue to destigmatize this diagnosis, advocate for patients out there, and normalize conversations that have to deal with our bowels. Next slide. So I like to show this to my patients to highlight that, we all have stress. And if you look at this cycle and start with number one, if a patient's been referred to me for the management of their GI condition by a clinician, we start to kind of discuss how you might feel something in your stomach. And that can then lead to thoughts of, oh, here we go again, or I've got to get out of the door and I'm going to be late. And if I'm late, my boss is going to think I'm not capable of doing my job. And if I can't do my job, I'm going to get fired. And if I get fired, I can't put food on the table. And we start to see how our cognitions can very easily get taken away from us and snowball. And in this patient population, we do see more catastrophic thoughts. We see a lot of black or white thinking, and we call those automatic thoughts in the cognitive behavioral therapy world. And those thoughts can then lead to increases in anxiety, depression, embarrassment, fear, shame. And when we feel those emotions, it ramps up our sympathetic nervous system, which is a part of our central nervous system that drives that brain-gut connection. And you can think about the sympathetic system as the fight, flight, or freeze response. And that's going to lead to increased muscle tension, your heart rate jumps, your pupils will constrict, you get shallow, short breathing. And even for somebody without GI distress, they can experience GI distress with sympathetic arousal. And once that's kicking in for somebody that initially had a GI discomfort, it's going to worsen that symptom. And so then you're stuck in this cycle. And when I show this to somebody, a lot of times I get the head nod and they feel validated, they feel heard, they feel like, how did you know this is happening to me? And it really then starts to allow me to explain some of our cycle breakers, which are where these X's are. And, I think for most people, a gentle diet cleanup can be really beneficial. So we've got nutrition support right there up on the top where, again, not everybody needs a restrictive diet, but maybe just some gentle nutritional support. But then diving in, and I don't provide that. That's Kate's job and my amazing colleagues. But what I can help to provide is different evidence-based behavioral therapies through cognitive strategies and relaxation training the modifications of arousal techniques that really help with our motility and that restoring that brain-gut connection. Next slide. So I'll just briefly touch here on, where getting the right person to the right care is pretty critical at this point, because just like there's an access issue for registered dietitians that are expert in GI conditions, the same is true, and probably even more so for mental health providers, as there's about 400 GI mental health providers in the world. So if a patient is experiencing increased or more severe levels of anxiety, depression, unresolved trauma, more significant eating disorders, we want to prioritize those patients to general mental health providers and or experts that focus in on trauma-informed treatment or eating disorder treatment, because the work of a GI behavioral therapist is going to be focused on really diving into the management of their GI condition. And so those therapies of GI behavioral therapy are not as effective if a patient has more severe mental health symptoms. So we want to be thinking, does a patient need more comprehensive mental health treatment, maybe medication management with a psychiatrist, and or working with a general mental health provider, and prioritize those patients there first. If a patient is really focused on strategies to address their GI specific anxieties or mood symptoms, and mood symptoms can be, mild to moderate depression symptoms because their symptoms are so impactful on their life, then I think that that's a good time to begin to consider making a referral to a GI behavioral therapist. And that's going to be delivered by either a doctoral level psychologist or a master's level clinician who has received training specifically in psychogastroenterology. Now, I think really emerging field, and what's I think very exciting about increasing access to care, is the emergence of GI digital products, and Nerva is one of them. And I don't get paid by Nerva to say anything like this, but I think the fact that if you're considering a patient for GI behavioral health treatment and they don't need more comprehensive mental health services, and they don't have access to a GI psychologist, then I think these digital products are really filling a much needed area of improving access. And so if a patient has access to good internet, then I think it's something to consider. We know that a product like Nerva, and there are a couple others out there on the market that are very evidence-based in terms of using science and research to inform the protocol that they're using. I think it's also important to say there are a lot of products out there that are not. And so just being a good consumer of that information and looking at what they are and how they created that product is certainly important. So briefly, we can kind of think about the stoplight situation here. I've covered this a little bit more, or I just covered this, so I'm not going to go into detail, but you can just take a snapshot of this to help inform decision-making in terms of making a referral to a mental health provider.
Oh, did I give you enough time?
Yep.
Take a snapshot.
I think you'll have access to the slides. Just again, this is what a bit more of a wordy slide, but I think that, sometimes a medical provider can make a recommendation or can prescribe a neuromodulator for a patient. And, if they are not familiar with them and they go home and Google and recognize, wait a minute, my gastroenterologist just recommended an antidepressant. I'm not depressed. I'm not taking this. And then they show up in your office, whether you're a dietitian or an APP or a psychologist or a psychiatrist. Probably a psychiatrist would be the perfect person to explain this. But at least in our clinic, we provide a lot of psychoeducation on this and highlighting that, meta-analyses have found that TCAs, tricyclic antidepressants, and SSRIs, when compared to placebo in patients with IBS, it was the TCA that can help with abdominal pain. But I think important to know is that it can also worsen constipation. So maybe for that patient with IBS-D, a TCA should be considered or can be considered, especially if a patient is interested in medication management. And then vice versa, we find that SSRIs may worsen diarrhea. And I see this a lot because SSRIs are very commonly prescribed to help with anxiety and or depression. And so sometimes a patient has been prescribed their SSRI by a psychiatrist or their primary care doctor, and they didn't tell their doctor that they had IBS, and then their IBS worsens, and especially IBS-D. And then it really becomes kind of a tangled web. So I think that, while these medications can be really helpful and commonly prescribed for patients with IBS, oftentimes at lower doses than we would use if we were hitting a therapeutic dose for the management of mood or anxiety, really going over the education and the why we're prescribing these is important. So these are the common, most evidence-based brain-gut behavioral therapies. And a lot of times in clinical practice, we're incorporating different aspects of these. So I like to think about the term brain-gut behavioral therapy as describing psychological interventions and theoretical orientations that have been derived and focused on the management of GI conditions. And I think this is what makes a GI psychologist a bit unique in that oftentimes patients really need this tailored, unique approach. And so being able to address different lifestyle, addressing sleep, stress, exercise, nutrition, and then weaving in aspects of cognitive behavioral therapy and gut-directed hypnosis, mindfulness-based interventions. You can't necessarily protocolize that in every patient. You can, and people do, but I think that most patients, knowing that they all have a very unique microbiome, need a very unique approach. So while I love our digital therapeutics, I don't think I'm at risk of losing my job anytime soon, because some patients really are going to need a more tailored approach, and we can supplement with some of these other products available. So a little deeper into what the GI psychologist does, and we really are not just helping a patient cope with their symptoms, but it has been found that our brain gut behavioral therapies actually do impact the microbiome. There's been recent research showing that CBT has been found to address the brain gut microbiome axis, and this is very emerging research out of the University of Lin Chang's group and Jeff Lachter's group. And so I think, the concept around the use of these interventions that we're just helping people manage is really evolving. And I think that that's really exciting. And patients are also, I think really excited about the idea that, this is actually having a profound impact on their gut and how they function. So, taking these ideas that how you think, how you feel, how you behave really happens a lot. It can impact that bi-directional communication pathway between your brain and your gut. Some basic statistics and kind of highlighting that these therapies are evidence-based and durable too. And also I'll talk briefly about those pathways that I was just touching on, that our brain gut behavioral therapies, when applied in a correct way with a certain skill set, can affect visceral hypersensitivity. And so I love describing and teaching patients what visceral hypersensitivity is, because again, they've been told at times in the past, perhaps, that, your pain it's not there, it's there, but we can't do anything about it. There's no organic reason for your pain. And when it's described in that way, people feel like, well, you don't get this. You're not living with this pain. And so explaining to a patient that it's real pain, it's nerve pain. And when you feel that pain, your brain is focusing very closely and intensely on the pain, which then amplifies the pain. The pain sends signals up to the brain. The brain says, yep, I feel that. I think I feel it even more. And you get stuck in this vicious cycle. And also sharing with patients that we know that people with IBS, their brain has a difficult time down-regulating those pain signals. First, they go, oh, so the pain is real. And second, I'm able to say, yes, and we can make it better. We can work together. And I think that's very powerful. Certainly, there are medications that can impact motility and hypersensitivity and pain, but not all patients are going to respond to that. And about 50 to all the way up to 80% of patients that have been refractory to medical treatment can still have response to the variety of brain gut behavioral therapies that we have. And when we think about the number needed to treat for these therapies being 3 to 6, if you compare that to any pharmaceutical out there on the market, it's better. And also there are very few side effects, which patients also love. So I think that the other thing that I'll just stress is that the more research we do, and I guess a blessing out of the curse of the pandemic was more research was performed to identify that the therapies are just as effective whether they're delivered in person, in groups, or virtually. And if you would have asked me 3-4 years ago if my practice would be 100% virtual, I would have 100% told you no. And yet I still continue to practice virtually. So I think it improves patient participation in their therapy. I have a far less no-show rate, and people get to learn these strategies in the comfort of their own home. Next slide, please. So I kind of just touched on this, but basically the efficacy is very strong, and the most research has been done on cognitive behavioral therapy and gut-directed therapy. So there's over 40 years of research looking at gut-directed hypnosis for the management of irritable bowel syndrome, and then that research has progressed to include other disorders of gut-brain interaction. And so I think that as we begin to explain to patients the benefit, the efficacy, the durability, meaning that once you complete these sessions, your symptoms continue to be improved, the buy-in is not hard for people. Next session. So some of our targets, and I've also covered this a little bit, but I just wanted to also highlight this multidisciplinary approach. And that while some patients may do well with just behavioral therapy, in a lot of patients, it may be that we need to combine therapies and really work together to address all of those mechanistic targets that we're aiming for. So this slide just very nicely outlines some of the availability of treatment that's for patients right now in the state of 2024. So a little bit about gut-directed hypnotherapy. I could give an hours-long talk on this. And again, one of those things where if you would have asked me if I'd be doing hypnotherapy as a clinical psychologist on an almost daily basis, I, again, would have told you you're crazy. But the proof is in the pudding, really. And so the research started with fully scripted, validated protocols that there are two main ones, the North Carolina protocol and then the Manchester protocol, ranging from 7 sessions with North Carolina and about 12 or 14 sessions with the Manchester protocol. And those were focused on IBS. And we now use hypnotherapy for dyspepsia. We use it for upper GI conditions like functional dysphagia, globus, and functional heartburn. So the idea behind gut-directed hypnosis is there's no bell going off and clucking like a chicken. Patients, as soon as you get over the stigma and you as a provider feel comfortable talking about this, they really find it to be a very pleasurable intervention. But also as you talk about the fact that these are validated protocols that have long-term effects, they show improvements in symptoms, again, for patients that have been refractory to other treatments. I think that as long as a patient is open to trying, because I think a lot of times the patient will say, I don't think I'm hypnotizable. And I'll say, well, are you open to trying this? And they'll say yes. And I'll say, well, great, because the research shows it's more important for you to be open to trying this than your hypnotizability. Even I myself, I'm a pretty low hypnotizable person, but I have gone through the hypnosis protocol and find it to be really interesting in the way it works. So, I think where the market is moving, again, is that digital therapeutics have taken our, one-on-one work that we've been doing, and it's now disseminating these strategies more widely. And the reality of hypnotherapy is that I am assessing each patient, and you can go on to the next slide. It kind of highlights what I'm talking about. That as long as a patient does not have ongoing significant psychopathology, so no severe symptoms of anxiety, depression, trauma, dissociative symptoms, psychosis, then, and they're open, and especially for the patients that are very aware of that hypervigilance and hypersensitivity in their symptoms, they recognize in stressful situations they're more likely to have their symptoms, then these are great patients for gut-directed hypnosis. And the research has shown that, it doesn't matter what type of IBS a patient has, gender doesn't matter, personality traits, their hypnotizability, as I said, none of that matters. It's just those factors on the bottom of that slide. So when we think about the different types of behavioral therapy, if I have a patient that comes in and I can identify their maladaptive cognitive processes, they're catastrophizing, they're engaging in a lot of avoidant behaviors, they're very inflexible in their thinking, I'm probably going to prioritize starting CBT with those patients while also introducing them to some relaxation strategies that are going to help calm down that autonomic arousal. And then maybe I'll incorporate hypnosis later in sessions, but that's kind of how I start, is especially if somebody's very stress sensitive, we're going to start likely more hypnosis. If their cognitive processes are more pronounced and they're avoiding a lot of things, then we're probably going to start CBT. And as we wrap up, just a couple slides on this idea that really, a lot of times, as Kate pointed out, food avoidance, occasional food avoidance in order to avoid those harmful symptoms, those painful symptoms, is not uncommon in people that are living with GI conditions. However, it can become a very slippery slope pretty quickly. And so as people that are working with this patient population, we want to be asking about the relationship with food. And this is just an illustration to show how we can move from occasional food avoidance to disordered eating to then patients that, maybe they started to avoid food for symptoms, they lost some weight, they didn't really mean to, but now when we're talking about returning foods back into their system, into their life, they're like, I don't really want to gain weight. I'm kind of happy with that. I don't know. And so we want to really work to prioritize care for these patients so that they don't progress to that eating disorder that needs far more comprehensive care. And this just highlights that about 50% of patients that are living with an eating disorder also meet criteria for IBS. And given the, the overlap of these types of needing to think about food and the potential for making recommendations for restrictive diets, it's just really important that we ask all of our patients about their relationship with food. And this can be done by anyone in really the GI care space. And these would just be some of the warnings that we'd be looking for. Evidence of body dysmorphia. The patient may be saying that there's nothing wrong, but we're looking at labs, and labs are concerning. They continue to restrict when they're already engaged in a restrictive diet. They're refusing to reintroduce foods, even though it's a part of the protocol. And they might not be showing as much concern over their restriction or their weight loss. These are the little red flags that we really want to be mindful of and have sometimes hard conversations with patients about our concern as clinicians and making sure that they have the right treatment plan. And this outlines what it might look like for a patient who may have some disordered eating. And this might fall into the patient category of avoidant restrictive food intake disorder. So the patient's avoiding food to avoid symptoms. They're not avoiding that food because of body image. and it hasn't quite progressed to a full-blown eating disorder, we may all be able to work together to ensure that we're able to develop a treatment plan to help that patient address their treatment goals. However, we each need to be assessing that patient and kind of being mindful that if things are not going in the direction that we would like them to, we may need to progress to an eating disorder specialist on the team. And so finally, this was an article and research produced by Dr. Simone Peters looking at the randomization of patients to the gut-directed hypnosis protocol and low FODMAP diet. And what I loved about this research is it basically showed everybody did get better, or most patients got better. Their improvement in quality of life and also symptoms. However, those that received gut-directed hypnosis had some better outcomes in terms of anxiety and psychological indices, which is not surprising. A diet is not meant to do that. But what this highlights is that if we don't just have to recommend dietary therapies, that especially for a patient that has a history of eating disorder, we don't want to put heavy focus on another restrictive diet for the management of their IBS. And so hypnotherapy, whether it be digital or in person or in a group, may be a great option for those patients. So we'll leave you with these resources. And again, I think you'll have access to these slides. And so our key takeaways are on the next slide. We recognize that GI care is very complex and that when we take this team approach, not just the patient benefits, but oftentimes the provider does too. And nutrition approaches are preferred. And I think must be prioritized to working with a GI dietitian. So a registered dietitian who has expertise in training in gastrointestinal conditions, which is different from a registered dietitian seeing general patients. And then it's important to prioritize the right patient to the right psychological or nutritional treatment. And we know that eating disorders and disordered eating are prevalent in our outpatient GI setting, and more research is emerging and is needed in this area. And this can increase to the general population as well. So it's something to be mindful of when we're assessing and talking with patients. And IBS is heterogeneous. One size does not fit all for all patients, and each patient deserves the right treatment plan. And we know that all of you are motivated to provide that for your patients. So I think with that, we thank you so much for joining us. And if Claire will allow it, I think we'll take a couple questions.
Yes, thank you so much. That was really excellent. And I know we are a little bit over time, so I just have two quick questions, one for each of you, and then we'll wrap up. But really, it was such a great talk. The first question is for you, Kate. It is, when a patient is doing low FODMAP elimination phase for 4 to 6 weeks, has reduction of GI symptoms, but still deals with weekly but less intense bloating and abdominal pain with fluctuation of mushy and soft stool, would you start the reintroduction phase? The person who submitted this question said, I can get confused when to start reintroduction phase if the patient still struggles with significant GI symptoms, and how to identify their triggers.
Yeah, that's a really good question. So there are times when I try to follow up with the patient 2 weeks post the diet, because some of my patients feel better by 2 weeks, and then we can start the reintroduction. I like to start it as soon as possible. But for those that are maintaining symptoms, but you see partial benefit, it would be a return to the GI doctor, as at least a conversation to see if there's anything else that they can think of that we could implement in a week or two, just to see if we can mitigate those sort of residual symptoms. Ideally, I like to get it at 2 weeks so I can start that process so I'm not keeping them longer than 6 weeks. So, by 2 weeks, you should have a really good signal where they're going. And if it's like good, but not really good, I might inform their GI doctor that maybe something else is going on, and at least start, in trying to better them with another treatment.
Awesome. Thank you. Megan, this question is for you. Can you talk a little bit about how you speak about hypnotherapy with your patients that might be more hesitant to trying it or have never heard of it and think it sounds a bit woo-woo?
Well, I explain that I'll put them under a deep trance. No, I'm kidding. I use some humor with it, that they are never going to be made to do something that that would be unethical, right? So they never lose control is very important. That I'm not using any suggestions that would be uncomfortable, and also the suggestions are very focused on the management of their gut. So I kind of talk about the stages of hypnosis and basically also highlight that if they've ever done any guided meditation or guided relaxation, or even, guided muscle relaxation during the Shavasana part of a yoga class, that these are all times where they are being guided in terms of relaxing their body. And in that very relaxed state, hypnotherapy combines very pleasurable, oftentimes nature-focused imagery with suggestions that are targeted to reducing uncomfortable sensations in the gut, reducing how much our brain focuses on sensations that it doesn't need to focus on, and then returning back by count. We count to open our eyes. So, if a patient is hesitant about doing this, I'll often walk them through a guided imagery practice and show them that this hypnosis is really not all that different. I think also highlighting that I'm creating a safe space, that in order to do hypnosis, we first do a very thorough clinical psychological intake where I'll ask about their history with their GI symptoms, what they've tried for symptoms. I'll ask demographic information, mental health history, lifestyle. So we're working together to identify which evidence-based strategies, and I'll also show them the science. So I'll show that, look, we've developed these protocols after 40 plus years of research. And I personally wouldn't be doing them in my practice if I didn't think that, so many people would benefit from them. So a lot of question asking and answering, and really working to make that patient feel comfortable. And I would say probably maybe 1 out of 100 patients might be hesitant if I give my whole kind of explanation. And really, I've been doing this a very long time, and on less than a hand has anybody asked to kind of stop the protocol or that they didn't want to do it. So that's thousands of patients that may have moved from hesitancy to like full buy-in.
Claire, can I just say one thing? I know we're done, but there was a lot of questions on the feed about pelvic floor dysfunction and pelvic floor physical therapy, which I refer so many of my patients and may be very relevant to the patient case that was just mentioned. But Pelvic Guru has a registry for those of you. I don't think it's international, but for those of you in the US, is just another resource to find a provider that offers that service, because I find that it's high on my list for many of these patients with IBS. So I just wanted to cover that long list of interactions on that topic.
Awesome. Well, I really appreciate it. I know we didn't get to all the questions, but for the sake of time, we'll wrap up here. And again, this was really amazing, and it's such a treat to have you both. So I appreciate your time. And again, I just urge everyone who's here to check out the Mind Your Gut book and also the Gut Health podcast with these two. This was just dipping your toe in, but there's much more on the podcast and in the book. So thank you again.
Thank you.
Thank you.